Yes, I'm coming.
This meeting is being recorded.
We'll start. Yeah,
Can we start
now? Yeah, I am.
Can we start running?
Yeah, no problem, no problem. We'll start. We'll
Yeah.
start. Who is talking about? Who is welcoming? Who is welcoming with us, sir?
I think Dr. Kasha will do that because he is our.
Okay, so you
Yeah.
can start with that, and then Selvaraj sir will inaugurate and talk, and then I will talk. Okay.
Yeah.
Shall we start? Hi, Dr. Vijay sir.
Hello, sir.
Hi.
Sir, మీరు స్టార్ట్ చేయండి then we'll.
Yeah.
Or do you want to wait for some more delegates to join? Delegates are joining.
Okay. Just wait for.
We'll wait for 5 minutes
Sure.
because I think 145 registrations have come, so people might be joining. Hello,
Yeah.
can you hear me?
Yeah. Sure, sir. Sure.
Yeah. I think so many people have registered, but maybe they will take another 5 minutes
Yes,
to
sir.
log in. It's increasing anyway. Excuse me, Raghav sir is there?
I
Hello?
cannot see Raghav sir's profile actually.
Okay, he is there. If he is there, please call him also.
Dr. Raghava,
Raghav Dutt sir.
I'll call him now.
Yeah. Please tell him to join for at least 5 minutes and go.
Raghav sir number is coming switch off, but
Okay.
I don't know. Maybe in the names there are other faculty doctor showing, but we don't know who is that.
Okay.
Then we click change, sir. Faculty doctor అని ఉంది కదా దానిపైన క్లిక్ చేయండి.
Narasimha Rao sir has come. I can't see him.
Sir, I am Dr. Jivesh Murthy. I am
Hello, sir.
unable to-
Oh,
Namaste, sir.
good
Good
evening,
evening.
sir.
Good evening, sir. Good evening, sir. I am
Good evening,
unable to change my this name, faculty doctor. It is like that only.
Hi.
Hope you will pardon me this time. I'll try.
Okay.
Next time I'll try.
Dr. Vijay Murthy
Sir.
sir will give the introduction,
Yes, sir.
and then we can go ahead whenever you say ready.
ఏం లేదు సార్, మూర్తి సార్ ఇంట్రొడక్షన్ ఇస్తే మళ్ళా మన సెల్వరాజ్ సార్ కొంచెం ఇనాగ్రేషన్ చేస్తే ముందు వెళ్ళిపోవచ్చు.
Done. Ante.
Shall I? You tell me, sir, when to start. Then I'll start.
Yeah. Please welcome after Sarvaj sir is come back.
Yeah, I'm here running.
సెల్వా సార్ ఇస్
Okay,
దేర్. యా.
Yeah, I'm here running.
Start.
Anand sir, your voice is not clear. It's breaking.
Mine right. Mine right. Hello.
Yes, yes, Anil sir, yours.
Yes. I am traveling in between trains only. I have not reached.
Okay.
Kerala rains.
Good evening, I'm Dr. Nityananda.
Sorry. Yeah.
Nityanand, good evening.
Yeah, good evening, Dr. Salva sir. How are you?
I'm fine, Nityanand. How are you?
Good, sir. Good, sir.
We are very happy, sir. Selvaraj sir came all the way to our conference to Warangal.
That was a nice
Yeah.
station to
Yes.
interact with a lot of people there.
Yeah. We are very happy, sir. Sir could spend 2 days with us.
Thank you. I must thank you for the courtesy and hospitality.
Thank you, sir.
Nityanand sir.
Yes, sir.
You know, I think next month that is August is Tamil Nadu and September is from Karnataka. Okay.
Yeah, Bharat has told me we are
Okay.
getting ready.
Yeah, that's
Topic is fractures around the knee
Whatever
and
it is.
complications.
whatever. What is it?
కాశీ సార్ స్టార్ట్ చేద్దామా ఏంటి?
I think
Kerala.
we should.
7 అయింది స్టార్ట్ చేసుకోవాలి.
Start చేసుకుంటే better, sir. But somebody could not tell, they can give their talk later also.
Okay.
Yes,
This program is anyway recorded and online.
And
Shall we start, sir?
Yes, sir.
We will start.
please start. Welcome address.
Thank you, sir. Thank you. I'm just 2 days back. I'm a budding president. Only 2 days old. President of Telangana Orthopedic Surgeons Association. TOSA. So we from TOSA are very happy, sir, to share the ICL platform of OASIS, which benefits most of us in practice, and not only in practice, in teaching as well. And we are very happy that we are given a good important topic, that is trauma, that too in pediatric trauma. I feel it is very difficult to treat pediatric trauma because it's very difficult to understand the children, communicate with them, and not only communication, to get their controlled cooperation. They don't listen to us. But anyway, we have a good faculty today. We hope they will enlighten us of all the aspects of it. And we have an all-rounder also in this, that is Dr. Srinivas Kasha. So, when I have seen all this, he is one person without the tag of pediatric orthopedic surgeon. Sorry, the pelvic acetabular surgeon talking on elbow drop. That's nice. So now with this, I welcome all of you, sir, to this wonderful ICL. Welcome, sir. Thank you. Sir, please take over, sir.
Yeah,
Selvraj sir,
yeah,
your address and inauguration.
sure. Secretary General of OASIS, Dr. Anin, President TOSA, Dr. Murthy, Secretary TOSA, Dr. Srinivas Kasha, esteemed faculty, delegates. I'm happy to be a part of this ICL, in which a very important topic is being taken up. Pediatric elbow injuries are very difficult to diagnose, evaluate, and treat. Even a small mistake can result in disability for a lifetime. So you have to be extremely cautious in diagnosing, treating optimally, and restoring function and minimizing the disability. I'm sure Dr. Srinivas has put up a nice array of faculty with interesting topics. I'm happy to inaugurate this ICL. Thank you.
Thank you.
Neen, over to you.
Even we had our brochures ready only yesterday. Sessions are great. People, a lot of people are inviting. I won't be in the academic program.
Yeah. Anin sir's voice is breaking. I think.
Srinivas will get started.
Okay, okay, sir. So, Dr. Vidyasagar sir, can you please take over?
Yeah. So we are having total 6 talks, and the first talk would be by Dr. A.V. Anand, and his topic would be acute lateral condyle fractures management strategies. Rest others can unmute and mute and let Dr. Anand share his screen and speak. Dr. Anand.
Hello, sir. Good afternoon, sir. Can everyone hear me?
Yeah, we can hear you.
I'm sharing my screen, sir. Can everyone see the screen? Like,
yeah, please start sharing. Yeah, we can see your screen. Right, please go ahead. Your voice is not heard. Debulina, can you help?
Unmute yourself.
I'm sending him unmute request, not unmuting himself.
Dr. Anand, we can't hear you.
Anand, your screen says your microphone is disabled when you're sharing. Go to setting and correct it. Anand, you are not audible. You are not audible.
Better we call Anand and tell.
Yeah, I'm calling. I'm calling him now. I think Anand is not able. To log in. So his voice is not there. His voice is not there. So I asked him to re-log in.
No, the problem is in computer setting. The computer setting clearly tells that when microphone doesn't work. That he has to change in his setting. Or use a headphone.
Okay, then what do we do? Shall we talk?
Go with the second talk, I believe.
With the next talk.
With the second talk, I believe.
Okay. Then shall I start my talk?
Kasha sir, can he?
Yes, Dr. Jasagar. I think you have to go ahead.
Jasagar, I think you have to go ahead.
Yeah. So, can you all see my screen?
Sir, can you hear me now?
Yeah, Anand, we can hear you.
I'm really sorry. Shall I start or will you start?
Yeah. Please do that. I'll stop sharing.
Shall I start? I'm sorry, sir. There was some small confusion. You can hear me now, right? Clear?
Yeah. You start. Please start.
But I don't know. I am getting price.
Yeah, even I am down. I'm not sure why.
Why is that so?
Debulina, can you just find out? This is looking like Ekta Kapoor.
Mellow evening drama.
Hello.
Sagar, I think so. You should start with your talk because his settings is an issue. When he is speaking, it is heard, but the screen sharing, no, the screen is blocking. The system is blocking his microphone.
Agree. I think so.
Fine, then I'll start with my talk with everybody. Yeah. Can everyone see my screen?
Yes.
Yeah. So trash elbow is basically an acronym for injuries which can be missed easily and thrown in the trash, just like it is normal. That's why the name trash is there. So I'll just go with an example first. Here is a 5-year-old boy who had fallen outstretched hand. And then clinically, you see some swelling in the elbow and pain and restriction of range of motion. being 5-year-old child, we can see there is a ossified capitulum, there is a ossified medial side also internal epicondyle, whereas there's no radial head there, or it could be there somewhere hiding here in the lateral view. So such injuries can be considered normal, and then patient would be sent home with just analgesics. So that's the fragment which is lying, and it's totally outside the joint. And that's the MRI of the same boy showing the fragment. Actually, the bony cancellous part is articulating with the capitular cartilage. And hence such injuries should not be missed. With this case, I'll proceed. So we are like this truck driver managing a huge truck on a highway, but distracted somewhere else in this situation. So it should not be the case. So our learning objective would be to define the injuries, learn ossification and radiology, and come to a diagnosis. And I'll talk about individual cases later on. So this acronym is that radiographic appearance seemed harmless. So everything in the X-ray looks normal unless you have that special eye to look for what we are seeing, and then that would be thrown in trash. What are the examples of injuries? There are many here, but as we go, we'll deal with and we'll see what are the different types of trash injuries. Coming to ossification center, we all know the acronym CRITOE, C-R-I-T-O-E, which stands for capitulum, radial head, internal epicondyle, trochlea, olecranon, and last ossification is by lateral epicondyle. And it appears at 1, 3, 5, 7, 9, and 11. A 1 year earlier age can be considered for girls, and these are for the boys. And generally they fuse by 14 to 18 years, depending upon they are girl or a boy. What are the normal variations which we see? As seen here in the slide, the yellow arrowhead, this is the ossification speck, which could be considered as some other bone fracture inside, but that is actually multiple epiphyseal centers or ossification centers in the trochlea. And this is the same thing. And there can be also eccentric ossification in the capitulum, which is quite anterior here. So this is the part which we see in X-ray, and this is the part which we don't see in X-ray. So in very young kids, we should be cautious when we are calculating the anterior humeral line, and the ossification center is anterior here. So it could be eccentric sometimes. When we take X-rays, the normal elbow AP X-ray is in full extension and forearm supination. And similarly, when we take lateral X-ray, it's in 90-degree flexion with forearm supinated. We may need oblique and normal side X-rays in doubtful cases. So this is a wrong way to do it. And where we must maintain the elbow and the wrist at the same level as shown in the first figure. And the second, the arm should be parallel or should be almost lying on the table if you want to take a true elbow. And whenever I get a pediatric elbow, I look out for this fantastic 5. So what are those fantastic 5? First, at the age, whatever the child is presenting, look for ossification centers, whether they are there or they are missing. This is the first thing which we must see. Second thing, look for the anterior humeral line, whether it is cutting the capitulum. And third thing would be the Bowman angle. And then look for fat pad signs, which is a sign of displacement due to the effusion into the joint. And lastly, never miss this line, which is radiocapitular line, which shows a dislocation if it is there. So basically, to get to the diagnosis, a high index of suspicion is a must. We must take proper X-rays when needed. And if X-rays don't demonstrate what is required, then you can take the help of ultrasound, arthrogram, or rarely MRI. CT has a limited role because of the immature skeleton. So mainly these 3 utilities should be kept in mind. So what is are we in a hurry to identify them? The thing is, they heal so fast. So decision making is important. And morbidity can lead to loss of range of motion, pain, nerve palsy sometimes, avascular necrosis in case of radial head fractures. And then lately they can present with subluxation, malunion, non-union, and myositis. And then you're dealing with malpractice claims. What do we assess? Assess the localized swelling, look for bony tenderness, look for deformity, anything if it is there. And in neurological examination, the earliest thing which you can differentiate would be a 2-point discrimination and check for vascularity. And then look for soft tissues like skin tether and open wounds. Do not forget that there can be associated injuries also which can be there nearby. So first thing which we'll talk about is distal humeral physeal separation, which is commonly seen in less than 2 years. usually a result of birth injury or a child abuse, and mechanism is shear mechanism, and the child presents with pseudoparalysis, inability to move the limb. MRI, ultrasound, USG can help apart from X-rays. Look for nerve palsy also in these cases, and differential diagnosis will be posterior elbow dislocation and lateral condyle. So this is an example here. In the AP view, we see almost everything looks normal. However, if we see the ulnar and radius, they both seem to have moved in a little bit of medial side with a speck of calcification there, which is seen again in the lateral view. So that's a distal humerus physeal separation. Usually it goes into varus. You can see the anterior humeral line, and you can see the radiocapitular alignment is maintained. And these injuries, usually if you show to the parent, they won't understand. So there is a lot of unhappiness and suspicion. How do you differentiate between the lateral condyle fracture and the physeal separation? Arthrogram would help. When you inject the elbow joint with a dye, the joint line is clearly outlined in physeal separation because it's an extra-articular fracture. Whereas in the lateral condyle fracture, it would be around the lateral condyle fragment. And this is a MRI, which the patient presented to me with the MRI with this picture. So that's DH is a distal humerus and DHP is a distal humeral physis. We can see the separation there, which has occurred. And same fracture has healed about in 3 weeks time, and that is after 6 weeks. The child is not as unhappy as the parents are. Cubitus varus is there. And this is another case, similar case, managed with closed reduction and pinning early, and after 6 weeks having good Baumann angle and good range of motion. So that's the physis there. So generally it is enough to treat in posterior splint in undisplaced fracture or in delayed presentation. However, when you catch them early, which especially the displaced one, closed reduction and pinning is a good option. Open reduction is almost never done because of risk of avian and myositis. So if there is a deformity in neglected cases, you can treat it later with a corrective osteotomy. The second would be a Monteggia lesion, which is commonly seen in 4 to 10-year-old. It is different in child and adult because of the fracture pattern of the ulna, which describes the personality of the ulna fracture, and generally green stick, buccal, and plastic bowing. So don't be distracted with what is there in the mobile, and just be careful of the surroundings too. So that's what when we happens when we get a Monteggia variant. So this is a case example I want to show. The left hand side on your screen would be the affected, the right hand side would be the normal one. So what do we see? X-ray wise, there is no fracture. However, if you see the ulna bow, there is a slight volar apex of the ulna, whereas on the normal side, it's okay. If you see the other thing, radiocapitular alignment, it's missing on the affected side and it's normal on the non-affected side. So this is a thing which you should not miss in your practice. That's why if you see a clinically pain and deformity and you can correlate here in X-rays, then it would be fantastic, and never miss these proper AP and lateral views. Otherwise, you'll not able to get to the diagnosis. So that's there. So what we need is a 3-point pressure, gentle pressure over about 15 to 20 minutes. And then slowly correct the plastic bowing, and the radial head would ultimately sit in the position. And basically it's because of the shortening of the ulna and angulation. So another example, a green stick fracture of the ulna with a radial head dislocation. This also needs ulnar reduction when the radial head will fall back to its place. And the same thing was done by closed reduction and casting. And you can see the radial capitular alignment before and radiocapitular alignment and the bow corrected later on. So this is another example, a lateral dislocation of the radial head. This is the ulnar angulation. This is the radiocapitular alignment. And that's in the other view. And this is after reduction, we can see. And a pin was put, smooth pin, into the ulna to stabilize it and gain the length and angulation. What happens when we miss it? So this is a fracture which was there, which malunited, and the radial head dislocation was there. The child presented with a swelling in the cubital fossa, and then child underwent ulnar angulation distraction osteotomy with open reduction of the radial head. We didn't reconstruct the annular ligament because radial head was quite stable. And this is the R is for radius and C is for capitulum, and that's post osteotomy and stabilization. This is pre-op and this is after implant removal, post-op. We can see the good range of motion, supination, flexion, extension, and pronation. Another example would be a lateral condyle osteochondral fracture. Here the osteochondral fragment is seen, but in younger children it may not be seen. So you must get the help of ultrasound or MRI and then fix it, because it leads to articular incongruity. And this is another example of a medial epicondyal fracture, which happens to be incarcerated in about 15 to 18% of cases. And in a young child with unossified elbow, it may be difficult, but you can see there is a valgus and something is there, speck of calcification into the joint. And same thing is confirmed by the MRI. So medial epicondyle, when it is unossified, you always suspect that. And remember, don't confuse that medial epicondyle with the trochlear ossification center. That's why you take the normal elbow x-rays and if needed MRI also to diagnose it. This is the medial epicondyle which is incarcerated into the ulnohumeral joint. So this is a classic indication for open reduction of the medial epicondyle. And this is another example. So basically it needs to be reduced, open reduced, and then the fragment need to be fixed. And if needed, if there is ulnar nerve palsy, it needs to be decompressed at the same time. And this is post fixation and decompression. The screw need not be bicortical because it's a partially threaded. This is enough, and bicortical screw risks damage to the radial nerve. This is another example of a neglected injury. And if you see the AP view, the radiocapitular dissociation is there, and something is sitting between the ulnohumeral joint, that would be the medial epicondyle, and already there is a healed callus. And you can see the fragment lying here in the lateral view. So the child also has ulnar nerve palsy. You can see the clawing of the last two fingers. And this is a CT scan to demonstrate the same. And when you see, this is all the callus and extra ossification which is present there at the radial head. The capitulum is somewhere here actually. This is the trochlea. So this child came after 4 months of trauma, and this is the gruesome deformity. The child has prominence of medial side of distal humerus, and this is the CT scan showing the same. And what we did was a posterior open approach, and we did triceps VY plasty, and we removed all the callus and then articulated the ulnohumeral joint and put the radial head back into position, and removed the medial epicondyle and fixed it back to the position. This is post fixation, and we can see the elbow ROM before, almost only 20 or 25 degrees ROM is there. And 6 weeks later, the child has almost 0 to 90 degree of range of motion. So never miss them. Delayed treatment will be more difficult. So this is a medial epicondyle fracture in the unossified elbow. Arthrogram shows that the displacement is there, and then it was fixed on with the 2 K wires. So that's the fragment. So always suspect that there is an injury if you see clinically a large swelling on the medial side. Coming to radial head fractures, in ossified elbow, it's easy to recognize. What about the cases which the elbow is still not ossified? So I'll deal with the reduction manual later. So this is a 3-year-old girl who had fall on outstretched hand and pain and swelling with limitation of range of motion. If we take the true AP view, the ulna and radius are overlapping here, so we can't make out, but you can see the radial speck of radial head, and this is the metaphysis with the neck fracture there. In the lateral view, if you take only view, you definitely miss it because it's lying behind that somewhere. So same case which we showed before. So what needs to be done is, you need to do arthrogram if you are in doubt, because it's a displaced fracture, and then see the joint outline, see the fragment which is unossified, and use a varus force at the elbow in extension, and then slowly you flex and pronate the elbow and push your thumb on the fragment back into the position to get a partial reduction, and then your K-wire by a reverse Metzu technique from the distal radius can do the complete reduction, and this is post reduction. You can see the nice joint outline, and this is almost normal anatomical position. And this is another example described by Peter Waters himself. So this is a radial head fracture. Day 1, this looks normal. but 1 week later, the radial head is slowly subluxing because that fragment is getting displaced. So monitor them weekly if you are treating them conservatively for this subluxation, and if you see it needs fixation later on. So this article highlights the same thing. Early recognition is important for such injuries. Take-home message would be to suspect and investigate appropriately, and always maintain joint congruity whenever there is an intra-articular fracture. Thank you.
Thank you, Dr. Vidyasagar. That was really an excellent talk. Now, shall we invite Dr. Anand?
I think he's.
Can you hear me now, sir?
Yeah.
Can you hear me now, sir?
Continue.
Can you try once,
That was a very nice talk. Hello, can you hear me, sir?
Yes, we can hear you, but once you start your presentation, we are losing your voice.
In the meanwhile, if there are put up in the chat box, so that
Anand, again it is gone. It seems.
Not coming.
So
we can do one thing. You have to try with some other device. Anand.
Hello, can you hear me now, sir?
Yes.
Like this, it's with screen sharing alone, it's just stopping, sir. I don't know why.
Yeah. Do one thing. You share your presentation to one of us. Okay.
Okay, sir. Okay, sir.
So we will actually put it on, and you can talk.
Yeah, Dr. Anand, Deblina has put a message in the chat box. See and email her that your PPT, and then we can present it later.
Okay, sir, no problem. I think the other person can continue.
Yeah. Kasha sir, can you please go ahead with your talk to tell us your experience?
Sure. Okay, I need to. Can you see my screen?
Yeah, it's seen, sir.
Yeah. Thank you. Good evening, everyone. So, as Dr. Murthy sir told, I think I am the only one who is odd man out. So all the other speakers are, I don't know, it's going on. Just don't want it to move, but it's right. So all the other speakers are pediatric orthopedic surgeons, and I am the trauma surgeon, right? So as all of us know, I don't know, it's just moving on its own. Okay, so yeah, malunium or cubitus varus is the most common complication of supracondylar fracture humerus, and resultant medial tilt could be one of the reasons. And the problem is not a functional problem, more than that, it is a cosmetic problem. And the deformity usually consists of varus, internal rotation, and hyperextension in some cases. Then the treatment goals are mainly directed towards correction of the deformity, not for the function, as I told you in the previous slide. So correction of coronal, sagittal, and rotational deformities are to be addressed simultaneously, and prevention of elbow stiffness is the other most important thing. Various osteotomies are described. So among them, the most prominent one is French osteotomy, which was described in 1959. And even today, it has got very good outcomes. And these are the other osteotomies. And what I am going to deal with is the dome osteotomy and my experience with dome osteotomy. That's what I am going to talk today. So, and the French osteotomy, which was described in 1950s, and it has got a very good, correction. But one problem with French osteotomy is lateral condyle prominence. So, which is actually seen in most of the times, unless you do some other means to address that lateral condylar prominence. So this is how a lateral condyle prominence looks. My presentation is actually running, but that's the reason I am just bringing it back. So, so this is how
it on auto mode or something.
I don't know. I am actually,
because autoplay will be there sometimes when you time it. No, it plays on its own.
let's see that it's okay. So these are the techniques by which you can actually prevent lateral condyle prominence. Unless you do one of these techniques, you have lateral condylar prominence, which sometimes may again become a cosmetic issue. And this is what I was speaking about, the dome osteotomy, which was described in 1972 by Tagjan. And this is how it's going to be. Once you get a correction, it's almost looks like a normal elbow without any lateral condylar prominence. And the draping technique and incision is posterior posterolateral approach, and triceps is elevated from lateral to medial so that you get a posterior surface completely visible. And that's when you go ahead with dome osteotomy. I'll take you through the steps. And here, one more challenging thing is how to correct the rotation. So that in the same instance, you can also correct the rotation so that you get a correction of internal rotation, and hold it either with K-wires or with the help of a plate in case of an child, elder child. And this is how it is going to be. The draping in a transparent cling roll is preferable so that your limb is visible, and your triceps is draped from lateral to elevated from lateral to medial side. And that is the drill holes which I have put, and in a dome shape. And that's when I use my osteotomy, and then do a circular osteotomy like a dome. So that is the position. And it's going to be, you can check your correction immediately after your surgery. And if you are not, during surgery itself, you can check your correction. And if you are not happy, you can relook into it by doing it, correcting it more. So here is a 7-year-old male with a cubitus varus. And that is after correction of the same child with dome osteotomy and 2 K-wires. You can see a 4 months post-op. And it can also be done not only in younger kids, but also here is around 18-year-old male where you have got a cubitus varus neglected one. And here actually the deformity is in flexion. The hyperextension deformity is more common. And this particular patient was dealt with plating after correction, and K-wire was also used onto the medial side, which was removed after 6 weeks, and that is the correction after 3 months post-op. And you can see he has got neutral alignment and sagittal axis. You can see full extension possible, which was not possible preoperatively. That can also be addressed during your corrective osteotomy. And this girl is 22-year-old, and she is a nurse in our hospital. So I have operated this girl in 2009, and now she became in charge of our OT actually. And you can see cubitus virus neglected, and you can see the prominence abnormally on this lateral side, which I could address during correction. And I have used 2 plates because she is 22-year-old, and that is after correction, and immediate elbow mobilization was started for this lady, and that is the correction achieved. This is 6 months post-op. As I told you, she is in charge of our OT now. And 14-year-old, similar here, there is hyperextension deformity. And during correction, this can also be addressed by flexing the distal fragment. And that's the 6 months post-op of the same patient. And here is a 30-year-old man with neglected cubitus varus. And again, here it is in flexion rather than hyperextension. So dome osteotomy, and then 2 column plates, and you can see the correction. And he has got complete extension after 6 months follow-up. And young chap, cubitus varus after correction. So in conclusion, lateral condylar prominence is a complication of French osteotomy, and especially when it is done in older children. And dome osteotomy avoids lateral condylar prominence, and it gives inherent stability of the osteotomy. Can recheck clinical appearance on table by single bone cut, no alteration of limb length, and it can give more contact area and better healing. So why I actually chose this topic is last week I have seen this particular patient. This patient I have operated in 8 years back, where now this patient presented with some other problem, and I got an X-ray, and you can see normal looking distal humerus in this case, and normal carrying angle. And sorry, I'm really sorry. Don't know, it's yeah. So that's the previous picture of the same patient 8 years back. So with the cubitus varus, and sorry, I have got some problem in the presentation, but that made me actually, I've seen this patient last week, and that's when I thought of presenting this, all my cubitus varus cases treated with dome osteotomy. Thank you.
Thank you, Dr. Kasha sir, for sharing your experience regarding treatment of cubitus virus. Maybe we can have the questions at the end. Those who want to have questions can be put in the chat box. And now I would like to invite Dr. Roshan Jaiswal. He will be speaking on supracondylar fractures, and he will show us the steps to success.
Thank you, Sagar. Share my screen. Am I audible? Am I audible?
Yes,
Yeah.
yes. Roshan, yes.
So, steps for stress-free success. That's what the topic given to me in supracondylar humerus fracture. But I believe stress is always a part of our journey. maybe we get used to that stress part. But why do we get stressed up when we see or get a call from the emergency department telling that there is a child, and usually it's in the night when you're deep asleep and your resident calls you. Sir, there's a child with the elbow pain. He's not moving his elbow. He's having some problem in the elbow. But I find that the X-ray is normal. Now, this is the most stressful part of the whole story. When your registrar or your resident tells you that the child has come in the midnight, but the X-ray is not showing any injury, then the problem arises. But when the fracture is like this, it's pretty obvious that he's having a supracondylar humerus fracture and the diagnosis is evident. But when you see the lateral view, then again your stress starts. Whether he's having a huge swelling, what is his vascular status? Is he developing compartment syndrome? So you have to ask your resident. Any of the 3 A's of pediatric compartment syndrome are seen. Unlike the 5 P's of the adult, kids have 3 A's, which has to be looked for. But these 3 A's don't stand when there is an associated nerve injury. Examining a child for associated nerve injury is a difficult job, but a small test called as gun, fist, and paper can be done. So once a child arrives in your casualty with an elbow injury, the most important thing arises here is how not to miss those injuries. And Dr. Sagar has very beautifully shown in his radiological explanation of thrash injuries how not to miss those. We will have a recapitulation of the same again. Which to fix, when to fix, and how to fix. These are the 4 basic things what we have to see. Once we have ruled out that there is no vascular injury, there is no nerve injury, and the child is not in impending compartment syndrome, the important thing here is not to miss if any injury is there which may not be evident radiologically. It requires a proper clinical examination and radiology as goes for any case. The dilemma arises when the child is like this. Now, happily moving the elbow, but close observation of this child says that the child is moving the shoulder, not the elbow. The elbow is constantly in the fixed position and the radiograph looks indolent. But if you have a more closer view, you find that there is a fracture line running. There is a hemarthrosis there. There is a fracture line there on the lateral view and the anti-fat sign. The 5 fantastics what Dr. Sagar has mentioned. So fat pad sign is one of the most important signs to be seen. This child is having a type 1 supracondylar fracture. So when a child arrives with indolent looking X-ray, there's when the stress starts because you're not supposed to miss such injuries. So once this radiology part Dr. Sagar has covered, all the ossification centers have to be seen, the various lines to be drawn, the fat pad sign, which is the most important part, which we cannot afford to miss, presence of hemarthrosis and swelling around the elbow. I will not go in detail of these lines because Sagar has already spoken about them, but I would like to mention once about the fat pad sign. Normally there is 2 fat pads, one posterior fat pad and one anterior fat pad. As you see in this cross section here of the distal humerus and the proximal ulna, this is the joint, and whenever there is a fracture, this gets filled with blood leading to hemarthrosis. The anterior pad fat is actually anterior to the anterior part of the humerus. So in a normal lateral view of a child, anterior pad fat is always seen, whereas posterior fat pad is never seen. So whenever there is hemarthrosis, the posterior fat pad moves directly posterior, and which is always pathognomic. Whereas the anterior pad fat, because of its positional, it moves superior and anterior like this. So a superior and anteriorly placed fat pad is pathognomic of an intra-articular injury, which is very important to understand so that we don't miss type 1 supracondylar fractures. Like for example, in this case, as I show you this radiograph, the posterior pad fat pad sign is seen here, posterior, but anterior is seen superior and anterior. It's not dead posterior, unlike here. Whereas if you see it dead anterior here as the red arrow, it is usually not pathognomic of fracture. It is even seen in a normal radiograph. presence of hemarthrosis always tells that there is an intra-articular injury. It might be a type 1 supracondylar or any other trash injuries. Swelling around the elbow is an important point. As you see here, Dr. Sagar has spoken about this also, incarcerated medial epicondyle, which has to be seen. Coming to the supracondylar fractures per se, as we know, there are three most common types: undisplaced, posterior angulated and displaced, complete angulation, and the type 4, which are unstable both in flexion and extension. So when you try to reduce this fracture, it is unstable both in flexion and extension and requires different maneuver to reduce them. Once we have diagnosed it's a type 1 fracture, we are at ease. No need to panic because we have ruled out any vascular, neurogenic, or a compartment syndrome, which usually doesn't occur with a type 1 injury. A simple slab immobilization of such fractures is enough. In my practice, up to 3 years of age, I don't even give them a slab. I just give them a shoulder arm sling because they are so stable, they just can't move from their place. Type 2, there are two types of type 2, type A and type B as described by Wilkins. Type 2A is a pure extension type of fracture. It's a pure extension type of fracture. Whereas type 2B is extension with translation or angulation. These fractures are most important and cannot be missed. So the classification wise also, type 1, 2A are largely similar, but 2B is different because there is a medial collapse as you see here. If these fractures are not treated, we will have a problem. They end up in varus malalignment, and this can be picked up by drawing the Bowman's angles. Whether to pin them or not, pinning is not so important, but most important is to correct the medial collapse. And once you're correcting the medial collapse, they need to be pinned. Otherwise, these kids will end up like this on a long run. Type 3 are very simple to diagnose radiologically, which are completely displaced fractures. But the point of importance here comes is the timing of reduction, whether we have to do a close reduction and we require pinning or not, the configuration of pinning. But these two last points, I would not go into it. That's the pink pulseless hand and nerve injuries. We will not go into it detail here. Timing of reduction. There is a huge controversy regarding the timing of reduction in supracondylar type 3 fractures. Many surgeons believe that it has to be done as an emergency. Yes, largely it has to be done as an emergency, but it's more of an urgency than emergency given that there is no vascular injury or any compartment syndrome signs, the 3 A's of the pediatric compartment syndrome, which is also ratified by this retrospective study by Gupta and et al. And by Trafford, which has clearly shown that the treatment of such injuries, the outcome is not changed whether it's done within 12 hours to 21 hours. So urgent care is important, but not emergency care. Close reduction is the term for most of these fractures. We do close reductions for all these fractures. Previously, many surgeons used to put a figure of 8 cast, but now pinning has become the term or the normal thing for any type 3 fractures once close reduced. Why we pin? Because holding the reduction in cast is very difficult because we cannot flex the elbow too much. It leads to compartment syndromes, loss of reduction after the swelling comes down, and maintenance of the plaster is very difficult. In busy OP practice, calling the patient every second day, checking whether it's getting displaced or not. Once it gets displaced, then you have to convince the parents again, you have to go to the theater, do reduction again, put a pin. So all type 3 should be pinned. Now, the most important thing which comes to clinical practice is the configuration of pinning. We know this 3 configurations of pinning are there: 1 medial, 1 lateral, 2 divergent pins or 2 parallel pins. But why are we debating this pinning technique? This is largely because of the safety of pinning technique and the stability of fixation. Dry bone studies have shown that both medial and lateral pinning are equally effective, given that the lateral pin is divergent, not parallel. The added advantage of lateral pinning is obviously prevention of ulnar nerve injury, the incidence of which is 1 to 15%. How to prevent it? It's very simple. Do a lateral pinning first, extend the elbow joint, feel for the medial epicondyle, do a mini open technique, and then only put a medial wire. I largely in practice only use divergent lateral pins, but there are some specific indication for using medial pin as well. Whenever there is medial combination or a medial oblique fracture, the fracture patterns can be different, medial oblique and lateral oblique. Medial oblique fracture tends to displace medially and go into varus. So all medial oblique fractures and medial combination, as seen on the radiograph, should undergo medial pinning. So this reiterates the same thing. Lateral pinning is equally effective as medial pinning. Lateral pinning preserves ulnar nerve injury and it's very vital. But ulnar nerve injury while medial pinning can be prevented by extending of the elbow and taking care of the or doing a mini open technique. So what is the OR setup for doing this supracondylar humerus fracture? Many of the surgeons use this technique of inverted C-arm, but I somehow find it very difficult in this. The projector is kept as the base for the elbow to rest, and then the pinning is done. And many people do close reduction, put a figure of 8 bandage and do it. What I felt in my practice is, of late, kids with very high energy injuries come to the OR, and a lot of soft tissue stripping is there. Maintenance of these things on these tables is a difficult job. So I basically do it on a simple fracture table with a lateral arm support here, where the child's elbow will lie. I will use AP, standard AP view using a C-arm, and a standard lateral view by rotating the C-arm rather than by rotating the forearm. Why I do it? As this maneuver clearly tells here, this is the reduction technique, what everyone uses, or it's the described technique. Traction to get the length. In the second step, you are supposed to correct two things, that is translation and rotation both. If rotations are not corrected well, the fracture reduction is unstable. Even pinning will lead to loss of reduction. Rotations cannot be accepted, as well as medial varus valgus angulation. So once you achieve the length, correct the mediolateral displacement, you are supposed to correct the rotation. Here the problem comes. When you try to correct the rotation, it is by correction of the or rotation of the forearm. And once the rotations are corrected, we have to check it under the intensifier or C-arm guidance. But when you try to rotate the limb to C, like done here, this kind of displacements occur. Here you see that's a good reduction achieved on AP. There is some medial lateral opening and medial collapse on this radiograph. But now the arm is rotated like this, and you get a rotational deformity. To prevent this rotational deformity, I use a C-arm where the C-arm is itself turned around. Once the C-arm is turned around and you are sure that there is no rotational deformity, I correct the extension by flexing and directly pressuring on the olecranon. Once the reduction is done, forearm is pronated to lock the joint. We take radiographic assessment of the reduction. This is the lateral view. This is the AP view. On the AP view, you can see that it's well reduced, though there is some extension. If you draw the anterohumeral line, it's not completely reduced. Some amount of extension is still there. On the AP view, you see that the medial and lateral columns are well formed. It is not always possible to see this medial and lateral columns on the C-arm in the operation theater. Many times there is a lot of swelling and blurring of these visions. So to assess this vision, we do a medial and lateral oblique views to see medial and lateral columns. Once the reduction is confirmed, it is fixed with K wires, 2 lateral or 1 lateral and 1 medial. In this case, I have done 2 lateral and 1 medial wire because there was a medial sided combination. Once we achieve the reduction, we have to immobilize it in a above elbow slab for around 3 weeks. Literature says that you have to see the callus formation, then only remove the slab after 3 or 4 weeks. I don't do a post-op 3 weeks post radiograph. We remove the slab and we mobilize the child. The most important thing while mobilizing the child is it should be active assisted elbow ROM, not passive movements. I've never sent any of these kids to the physiotherapist, because if you send them to physiotherapists, they do it very vigorously and it leads to myositis. I hope I'm put some light, but still there is a lot of things to be debated and a lot of things to be sorted out. Thank you.
Thank you, Dr. Roshan, for sharing your nice experience. Now I would like to invite our Dr. K.L. Narasimha Rao sir and he'll be speaking on pulled elbow. Sir, please continue, sir.
So, can you listen to me?
Yes, sir. Yes, sir. We can hear you, sir.
Yeah. Wonderful evening for everybody. Out of all these 6 topics, I think this is the only one topic which gives a immediate happy result for the patient and as well as the family. And this is the only one procedure which can be done within 6 seconds, and you have a happy customer and a happy family. That's nothing else but pulled elbow. This is the child who came to my clinic yesterday, happily walking but refusing to use his left upper limb. He otherwise is quite busy with the toys which is in the clinic. And the day before yesterday, I think he has a little a fight with the other children. Probably during that time, the children has pulled his elbow. Since then, he's refused to use it and guarding it from his further usage. So this is nothing but a nurse-made elbow, which is another word for the pulled elbow. But this particular is a diagnosis of exclusion of a painful elbow, which has with a limited supination. He's seen the child who's keeping his elbow always in the pronation. So what will be the differential diagnosis for this? The other traumatic causes, which can lead to different fractures around the elbow, or sometimes.
Sir, can you make it full screen, sir?
Full screen.
This last one window like button is there down on the besides this 57%, sir.
Is it okay now?
No, sir, still it is not come full screen, sir. Besides the 57%, one small monitor like thing is there. Please click and try that, sir. On your right hand side, lower down, sir, near the volume.
On the right side corner, sir, slideshow, it is written, sir.
Below the auto preview, sir. Below the play auto preview.
Sorry. Yeah, this is the one.
Yes, sir. Correct, sir.
Can you see it now?
Still, it is not showing us full screen, sir. Somebody has suggested to press F5. I'm not sure. Try that, sir, once.
Okay, I'll do one thing. I'll just try to have a bigger screen.
Sir. Yes.
That may be a better one. Okay.
Sure, sir. Okay.
Rather than trying all different things.
Okay, sir. That's good.
Okay, now. So other things to rule out in this particular scenario is the infections, which is more dangerous, and sometimes this is the only way we can diagnose some sort of a congenital radial head dislocations for the forearm stenosis. So here you see this child. Here, what really happens here is when the child's forearm is being pulled, you just watch here. This particular radial head is being subluxated from the annular ligament. And this annular ligament, is being obstructed between the capsulum as well as the radial head. Okay, so this is the mechanism of the injury in this pulled elbow. So what is the incidence? The incidence is commonly before the age of 4 years, and most of these cases we see around the age of 28 months. But it is rare after 5 years age, because the annular ligament gets more tougher at the inferior incision, so that the radial head does not subluxate out of the annular ligament. So how do you evaluate it? Radiographs are really of no use. It is more of a clinical diagnosis. But radiographs we have to get whenever we have a suspicion of other injuries, when you see heaps of swelling, and to rule out other trauma. Sometimes when you send these children for radiographs, we are given with a surprise. The radiographer, he tried to take a elbow X-ray AP view and try to supinate it, or sometimes pronate it, and you may get sometimes a spontaneous reduction during the taking of radiographs. But sometimes ultrasound is the thing necessary when you want to really confirm the diagnosis, when really the mechanism of injury is not evident. Whenever it is not unwitnessed injury is there, probably the ultrasound may be very useful, or whenever the physical examination is inconclusive. Here we see that the annular ligament gets entrapped between the capsulum and the radial head. And also sometimes we can rule out the infections in this particular scenario. I rarely got any ultrasound so far for any of my children. So what is the treatment for this? The treatment is to reduce the subluxated radial head. Either we have two mechanisms. One is a non-operative, an operative which I have never done, nor have seen any of my colleagues doing it. Most of the cases we do the non-operative, but we must be very, very, very sure that there is no fracture present prior to any of these manipulations. Otherwise, we may displace the undisplaced fractures. Operative, yes, then if it is very chronic, symptomatic, and that the subluxations could not be reduced. So what is the mechanism of reduction? If you can see here, this is the one particular technique which is used, is the supination and flexion technique, where the child's forearm is held with the one hand, and another thumb which we see here is placed over the head of the radius, and it is supinated and flexed. And suddenly you can hear a click, the way the annular, the radial head being reduced. So other technique what we can use is the hyperpronation technique. Here we see this, the child's limb is being pronated, and during this process the head can get reduced. So they say that hyperpronation is less painful than the supination technique.
Sir, the slides are not moving, sir. The technique slides. Yes, yes, we can see now.
Here, can you, I don't know if you can see this.
Yeah, we can see, sir, now.
Can you see it? Can you hear this child's arm is being supinated and flexed? These are the small videos here, what you're seeing that. And here is another technique where is the hyperpronation, which is supposed to be less painful when compared to supination. So at the end, here we can see that they are able to use. Here you can see that child is able to use the opposite limb. Can you see this video? Can you see the video?
Video is not playing, sir, but we can see the.
That person is able to use his left hand. Okay, after the reduction. So the complications mostly is the recurrence may occur. The child whom you have seen, this is the, I think, 4th time it is happening now is 4 years. Hopefully it should not have from the next year. And if it is usually recurrent, if the child is younger than 3 years, and initially the treatment sometimes maybe with a cast application to heal that particular annular ligament, which I have never done before. Thank you.
Thank you, Narasimha Rao, sir, for your sharing your experience on pulled elbow. Now we will call upon Dr. K.C. Srikanth, sir, to talk on radial leg fracture management in children. Please continue, Srikanth.
Thank you, Dr. Vidyasagar. Am I audible?
Yeah, perfectly.
Is the screen visible?
Yes, sir.
Right, sir. At the outset, I would like to thank OASIS team, Dr. Srinivas Kasha and Dr. K.L. Narasimha sir, for giving me this opportunity. Yeah. Radial neck fractures. They constitute approximately more than slightly 1% of all pediatric fractures and approximately 5 to 7% of elbow fractures in children. Yeah. That is, it is not very common. It is rather relatively rare or injury. Like if I look at my own census, our own cases, like over the past decade, I might have operated around 7 to 8 cases of radial neck fractures, operative. Most of them can be treated conservatively also. We'll see the indications and all. That is to say, it is not once in a blue moon we get to see a radial neck fracture, which needs surgery. Is the screen moving?
No, screen is not moving. It's still in the first slide.
Yeah. The mechanism of injury is fallen outstretched hand, like fallen outstretched arm with the elbow extended in valgus. The valgus, we have to remember this, that it is because of valgus injury. As you can see here, the radial head is pinched between radial shaft and the capitulum, and that is how the fracture occurs. And this is usually associated with the medial injuries as well, because it is a valgus force. Medially, we may have medial ligament injuries. More than that, the usual common association is a green stick type of fracture of olecranon. All we have to keep this in mind and check whether when we see a radial neck fracture. Classification. The most commonly used classification is Jude classification, where type 1 is non-displaced. Type 2 is less than 30 degree of angulation, like between the angle is between the radial shaft and the proximal fragment. Type 3 is between 30 to 60 degree of angulation. Type 4A is 60 to 80 and type 4B is more than 80 degree of angulation. Type 4B means, when I say type 4B, it's almost completely flipped fragment. The fragment is completely flipped or approximately 90 degrees. As Dr. Vidyasagar has shown, the radial head is almost all cartilaginous in children, and we get to see on X-ray only the radial epiphysis part, epiphysis and the ossific nucleus in the epiphysis. So when we want to calculate this angle, we have to calculate, probably it's easy to calculate the angle between the radial head axis and the line perpendicular to the radial shaft, like we do something in for Cobb's angle. This is the angle we want to calculate for grading. Most of the fractures, some can be treated non-operatively, like fractures which are less than 2 mm displaced, and fractures which have angulation up to 45 degree of angulation can be accepted in a child, very young child, like less than 40 degrees, or if the child, less than 10-year-old. Older child who is more than 10-year-old, we may accept till grade Jude 2, Jude 3 more than 30 degrees. Yeah, we have to go for reduction. Otherwise, we can treat conservatively. If you are in doubt, the most important thing to check is the forearm pronation supination. That is very important, because if the child is having good forearm pronosupination, then it is a very good indication for conservative management. And operative, probably we have to go when there is open fracture and where there is incongruent elbow, like in previous presentation we have seen where the elbow joint is incongruent, that is where there is a displacement or a dislocation. We have to keep in mind, and probably we have to do MRI. Close reduction techniques. The most common thing is the Patterson's manipulative technique, where with the elbow extended, we try to give a varus thrust and try to push the radial head back into the position. This is, and after giving traction, this is the most common Patterson's manipulative technique. Another technique is flexion pronation, where in flexion we have to pronate, at the same time put a pressure on the radial head fragment and try to put it back in position. Another technique is the Neher toss technique, where the distal fragment or the shaft is manipulated. The shaft is the radial shaft is displaced towards ulna, and that we try to bring it back into position and push the radial shaft radially or laterally, instead of just trying to place the radial head into fragment. We also try to push the radial shaft into the radially. Another method is Monson's technique, where in 90 degree of elbow flexion and in supinated position, the radial shaft is pushed back, pushed ventrally to align with the radial head. So some maneuvers we put pressure on the radial head. In some techniques we put pressure on the radial shaft. And this is a beautiful technique that is described by Dr. Maulin Shah, published in last year IJO, where the author has used first, we start with Patterson's technique, where they give traction and try to reduce the radial head, try to bring the Jude grade 4 to grade 3 or grade 3, and then the complete reduction is achieved by flexing and hyperpronating. The flexion and complete flexion and simultaneous flexion and hyperpronation is something the author here has added, and they have published 10 cases where they say they have got complete reduction, anatomical reduction in all the cases, and there was no need to fix the fracture. No need to fix the fracture. And the fracture, we generally have the tendency to immobilize the fracture in supination. But here the author has immobilized the fracture in pronation, saying in supination there will be some the fracture is not stable, and here he immobilizes in mid-prone position and just puts a cast, and doesn't use a K-wire or nail. And the results are very impressive. I personally haven't tried this. Definitely, I'm going to try next time when I see a severely displaced fracture. It is because it is very impressive, because probably we can avoid fixation also, the author says. And the other standard described techniques are Wallace radial head reduction, where radial shaft, we cannot push the radial shaft laterally just with the finger. We may have to give a small nick and try to push the radial shaft laterally while simultaneously putting a joystick onto the radial neck fracture. Well, when doing the joystick maneuver, we have to keep in mind the pin, posterior interosseous nerve. Actually, the pin is slightly distal to the fracture, so joystick directly, intrafocal joystick usually doesn't cause injury to the pin. So we can avoid that by putting joystick wire into the radial head directly and maneuvering, or we should not try to go more distal. And this point is especially important when you are doing an open reduction by Cocker approach, wherein we pronate and try to displace the pin out of the surgical field. And other thing is a Metisu technique, where titanium elastic nail is passed retrograde from distal radius and try to engage the radial head fragment. Actually, the bend at the end of the nail, if it is not adequate, we should give an extra bend so that it engages the epiphysis. It should engage into the epiphysis and turn to 180 degrees. Here the key is the intact periosteal hinge serves as a reduction. It not only gets the reduction, it also holds the reduction. So it's a beautiful technique, one of my favorite. This need not be done only with titanium elastic nails. We can commercially available titanium nails. We can use some wire, long wire like Elizero wire, and bend it. But I have not tried this. But I have always used this standard titanium elastic nails. What are the factors that affect the outcome? This is a Nancy group of people who have published the largest series of retrograde nailing. They say open, and it's commonly believed that open surgeries have poor results. So percutaneous leverage can also be added to it, because that will avoid by doing the percutaneous joystick, we can convert the Jude 4 to 3 and then get the remaining thing by retrograde nailing, because completely fluid fragment probably may not be amenable for just a retrograde nailing Metisu technique. This is a meta-analysis study which says because the radial fractures are rare, we cannot have a very large series. So this meta-analysis also says that closed reductions have higher success rate. Open reductions are universally said to have less poor outcome in terms of forearm rotation. The other complications are like radial nerve palsy, heterotopic ossification, AVN, radial nerve synostosis, transient pin palsy. Yes, transient pin palsy is very important. It may occur with manipulation, and it may occur when you do a joystick type of reduction. In our series of 78 cases, we have had 2 cases of transient pin palsy, out of which 1 case we used focal intrafocal joystick. But they are all transient. They are recovered in a matter of 3 to 4 weeks. How urgently should we do closed reduction of radial leg fracture? It is not something very serious or urgent like a supracondylar fracture, but at the same time, this article says, like, if you take up the patient early, if within 24 hours, there are more chance of getting closed reduction. If the patient presents late, like more than 24 hours, or if the fragment, if the radial leg fracture is Jude type 4, then probably you will not get closed reduction with just sedation or something like that. We will probably have to take the patient to OT. So that is my preference, is always to post the patient as early as possible, because the more chance of getting closed reduction. The more the delay, the more the chance of open reduction, the more the chance of poor result. Let me take you through some case examples. This is a 9-year-old boy who sustained radial neck fracture after a fall on outstretched hand. As you can see, he has a olecranon fracture as well, which was treated by a Metisu technique, where the retrograde nail is engaged into the distal fragment, proximal fragment, and turned to 180 degrees. We get the reduction, and we can also hold the reduction with that. And this is the 3-month follow-up of the child. And this is his clinical outcome, pronosupination almost near normal. A 2-year-old boy, 9-year-old boy, radial neck fracture again. If you carefully see, he has got a olecranon fracture also. If in doubt, in such cases, we have to take contralateral X-ray to see that it is indeed a fracture and not a ossification center. And this was treated again by retrograde nailing. Here we did not do intrafocal pinning. Even then, the patient had a pin palsy which recovered at 3 weeks. That is the 4-month follow-up. 11-year-old boy, almost completely flipped fragment. If you can see on the lateral view, the radial head which was supposed to be here is placed here. In intra-PCM image, we cannot even see the radial head on the lateral view. Can we get a close reduction of such a case? Yes, if we try, we can get. Here I've used a intrafocal joystick type of reduction to make the Jude 4 into Jude 3 or 2, and then get the remaining reduction by standard Medici technique. That's a post-op X-ray, immediate post-op, and that's a follow-up. A 4-year-old girl, I think this girl presented late or completely displaced fracture. We had to go for open reduction, and this is a very old of one of our series where we put a radiocapillary pin, and this is strict no. Radiocap pin should not be put radiocapillary. This is given theoretically. Practically, we didn't have a problem. We removed the pin very early. That's a different thing. But this is a strict no. If at all, we have to do open reduction and put a pinning. This is better to, like in this case, 11-year-old boy here. Here we cannot get it closed. We had to do open reduction by Cocker approach, and this is how we try to put a pin from the epiphysis into the metaphysis, or the other way around, but not across the joint, because if you put a radiocapillary pin, these children become very active in a few days, and there is a chance of pin breakage even if you immobilize with slab. This is the clinical outcome. Definitely there is loss of pronation. Open reduction results are said to be inferior to closed reduction. And usually it's a commonly loss of pronation that is more common than loss of supination. So the take home points are radial neck fractures are relatively rare injuries. They are valgus type of injury. The mechanism of injury is important because that dictates our reduction maneuver. And displaced fractures which are displaced more than 2 mm. Angulator fractures which are more than 30 degrees in older children, like more than 10. And younger children like less than 10 up to 45 degree of angulation can be accepted. These are very important because all cases do not need surgery. These cases can be treated conservatively. And close reduction technique, Patson's technique is standard technique where we give traction, varus, and try to reduce the radial head fragment into the joint. But adding this hyperflexion and hyperpronation as described by Dr. Molinsha in last year is a very good technique, very promising technique. And my standard or favorite thing is Medici technique, which can be augmented with pin leverage SOS, so that most of the fractures we can get it close reduction. Otherwise, we have to go for open reduction. Thank you for your kind attention.
Yeah, thank you, Dr. Shrikant. Now we have Dr. Anand still remaining. We'll just see whether he can start his laptop. He has another laptop. He's logged in on that. Let's try. Dr. Anand, you may continue, please.
Can you hear me, sir?
Yes.
I'll try sharing my screen, sir.
Yeah, Shrikant sir, stop sharing your screen.
I've stopped.
Please continue.
Yes, sir. Can you see my screen, sir?
Yeah, good.
Can you hear me?
Yes.
Can I start my presentation, sir?
Sure, please.
Yeah, hello, good evening, everyone. Sorry, there was a small glitch, so I got a little stuck. I'm not a very good techie, so I got a little problem. So no problem. So now I'll be giving my talk about acute lateral condyle fractures and management strategies accordingly. So as already we have seen, elbow injuries most commonly are because of Fuchs injury, that is fall on outstretched hand. And lateral condyle fractures are Salter-Harris type 4 fractures as they go through the entire metaphysis, epiphysis and all. So it's a very severe injury. So growth disturbances are rare because especially babies from 5 to 10 years actually have lateral condyle fractures more than younger children. So in that age group, especially rare, more than 7 years babies, there is only 2 to 3 mm longitudinal growth every year. So growth disturbance is still rare, but only coronal plane deformities are very common in these issues. So clinical examination is like any other elbow fracture, especially having swelling and tenderness localized to lateral condyle especially, and elbow instability in severe cases. I'll be talking about that. So next, when you get a radiograph like this, this is a very simple radiograph, AP and lateral. Simple AP and lateral radiographs actually can identify a fracture like this. But what if you get something like this? You get an injury like this, as Vidyasagar sir has talked about, what do you say, trash lesions. So you can just see that there is a lot of swelling, soft tissue swelling on the lateral side, and a faint line that passes, and you have a very high suspicion. This is a very, very important X-ray, because here the doors open out to the next level of investigation in radiography, that is internal. Then our guy thinks that yes, daya kuch to gadbad hai isme. So next, investigate. So then the next important views that you have to take are oblique views. Internal and external oblique views, especially internal oblique view is very, very important. As you can see, the entire fracture pattern, the periosteal hinge and everything available around it. So internal oblique. So always remember that a lateral condyle fracture will have 4 views. One view is one view is AP, next lateral, then next internal and external oblique. So these 4 views are a must if you are suspecting a lateral condyle fracture. I'll tell you something that has gone wrong in the last 2-3 slides of mine. I'll show you a disastrous case. So as we have already discussed, so according to the elbow injuries, I'll be talking about the radiocapitellar line. This is a normal anatomy. And when you're talking about elbow dislocation, here you can see the radiocapitellar alignment is gone, and also the ulna follows the radius. And another thing, with you see a lateral condyle fracture, the ulna and radius remain in the same position, and the radial capital line is gone. So next, when you see a supracondylar fracture, the radiocapital line is actually maintained in whatever angle you see, because it's an entire distal humeral metaphysis that is broken. And also when you see distal humeral separation, physeal separation also, you can observe that the radiocapitellar line is still intact, but the entire physis is dislocated and with the ulna intact. So magnetic resonance imaging is a little rarely we do when we suspect a very serious injury, and we understand that there are some soft tissue issues and we want to see others also, we go for magnetic resonance imaging. So when arthrography is one very, very important investigation that we do, and I want you to take a note here that we always do something called as an air arthrogram. This is an air arthrogram when we first inject air into the joint, and then see if we are exactly in the joint and able to see the air that's inside the joint. After that only we go for something called as a arthrography. That's the entire joint. That is the lateral part we are doing from the posterior part. So next, this is the arthrography, and this is the AP part of the post arthrography. After arthrography, we will be using more of omni-pec rather than urographin. Urographin is not, goes out veins out very fast. So as you can see the entire condylar part, the radial head, and the entire joint. With this, you can understand the fracture pattern even better. So when we are talking about classification systems, Milch is actually outdated and it is for adults, most of them. It's not at all useful in pediatric age group. So talking about Weiss et al. And Songs et al. Milch classification I won't be talking about, is not useful in pediatric age group. So talking about Weiss classification, he tells that the displacement less than 2 mm, this can be actually conservatively managed, and displacement greater than 2 mm with an intra-articular cartilage demonstrated an orthogram, but the articular cartilage will be intact and the joint line will be congruent in this kind of fractures. This also can be managed just with K-wiring and doesn't require too much compression, and sometimes can be managed conservatively also. But the third type, especially where the fracture is greater than or equal to 2 mm, and there is articular surface, and also there is contact loss, and also there is rotation of the fragment, then you definitely need to do something for this. So this is a more serious thing. But more commonly, what we follow is Songs classification. This gives an immense understanding of each of the fracture patterns and also the kind of interventions that we are taking for it. So a less than 2 mm type 1, it has only a lateral part opened out, but the medial part is completely intact, and it's just a kind of a hinged fracture. So we don't need to do anything for it, just memorialize the baby. And the important thing is the lateral gap and the medial gap. If at all the lateral and the medial gaps are almost safe, that is less than 2 mm, generally it is kind of stable only. But in third type alone, as the fracture completely exits through the cartilaginous physis, So at that time, you definitely, it is an unstable fracture. And type 4, when you talk about, it is kind of without rotation, but it has just pulled out from the main body of the humerus. And type 5 is the most dangerous one, which is completely rotated out, and there is too much rotation, and these are very unstable. So from stage 3, 4, and 5, these are very useful, and especially this can be seen in an arthrogram and in MRI. Those are the better investigations to take a SONGS classification. So management options, what are we looking at? We are looking at conservative management. When to do a conservative management, that is type 1 and type 2 SONGS, especially do really well in type 1 with conservative management alone. And next thing is surgical. That is, are we doing a closed reduction or open reduction? And then are we doing a K-wiring, or are we doing a combination, or are we doing a screw fixation? So I want to show you a case. The first case that I've shown you, that we have oblique views we have taken, right? So this case, as you can see, the medial hinge is still intact and it's not very badly displaced. So what I did, I just put the baby on slab and started observing the baby. This was after 1 week. And Taral sir used to make a very nice joke about it, that if at all your wife doesn't run away in the first 7 years, then she's going nowhere. So she's always going to stay with you. So I don't know, that might be changing now, but he used to joke like that to make us remember. So the weekly monitoring of this kind of fractures is very, very important. So as you can see, the metaphyseal hinge and everything are kind of intact and in the same position as we see in the initial X-rays. And then when you see here also, I find it very, very well. Like, I'm very happy with the position. So I can see the fragment clearly. So I didn't open the cast. I converted the slab into a cast. And then next week, this is what I see. This, I felt very unhappy because I was not able to see the fragment. When I'm not able to see the fragment, what I do, I remove the cast. Don't hesitate to remove your cast and take another special X-ray under your monitored vision, because your one decision is going to change the entire baby's entire life. You have to operate it or non-operative, decides a lot. So after 2 to 3 weeks time, this is the picture of the baby. The baby is having very good callus and there is no displacement at all. In the oblique view, Anand, you are a little bad, but I feel this will do really well. So next, another 2 weeks, I maintain the baby in cast, and this is the final picture. So the baby is saved from a surgery, and the baby is doing really well now. With full range of movement, the baby recovered after 5 weeks. So they put him on good physio. So with screws and K-wires, especially when we do a closed reduction procedures in lateral condyle fractures, most important thing is to do it under an arthrography. When you do it under arthrography, you're always having control of the fragment, and you know that you are going to put a K-wire, and then the most important thing is the dye should not be leaked from the fracture site, especially from the fracture site. If there is any leak, that means you're not having any compression in the fracture site, and definitely that is going to do bad. So next, the fixation principles are almost same as supracondylar fractures, and also screws gaining popularity these days and prove better in few studies. And unburied K-wires and unburied K-wires, that is exposed K-wires, are doing a lot better as compared to a study. And then screws and K-wires both are equivocal but differed by few studies. Actually, few studies tell K-wires are better, few studies tell screw are better. There is still a little confusion with that. So CRF with K-wire fracture in the lateral condyle. When you look at it, yeah, first what we do, under the CM, we try doing something called as a reduction maneuver. We try extending the wrist and then try seeing if the fracture gets reduced. Yeah, with little compression, the fracture is reducing really well. So this is doing really well. So what we do, we just put a small arthrogram and see, and then try pushing K-wires from the lateral to the medial side in a parallel way. And then I felt like there's another K-wire that is required, a little thicker one. So I put that. And then I can see, as you can see in the arthrogram, there is no fracture line at all. The arthrogram doesn't spill into the fracture line. So this is a very good reduction and it has very good compression. So post-op X-rays, the baby looked like this. So after that, after 6 weeks follow-up, the baby has very good healing and all, and we pulled out the K-wires, and the baby is doing really well. So this is one of the videos that we made during my stay in Mumbai. So with this, I'd like to take permission of the seniors to just show the posterior approach for lateral condyle fractures, because it's open reduction is a very big thing for these cases. So displaced lateral condyle fracture especially, and as you can see, the radiocapital line is disrupted. So this is one of the incision line, that is posterior approach that we take, posterior lateral approach. So we dissect into the joints and then go to the lateral condyle, and you can see it is a little rotated. So K-wire is then inserted into the fracture site, and that is used as a joystick. And then we clear out the fracture edge really well. And then what we do, we slowly rotate the fragment and make sure that the posterior blood supply, this is the place from where the entire blood supply to the lateral condyle comes actually. So this is doing really well. So what we do is we don't touch that part and just put the push the fragment into the position and drill in the same way, and the second K-wire is inserted kind of little oblique way, so to get good reduction into it. So next the third K-wire is introduced intra-articularly. So this is another trans-articular K-wire that we put cartilaginous K-wire, and we bend down, and we had to bury these K-wires because we did an open reduction, and baby gained full range of movements. And this was the post-op X-ray. It was reduced really well, and there was no leak of the dye also. And then follow-up 1 week, it's doing really well. And next 2 months later, it's doing really well. There's a little compression injury, but baby is doing really well. Then we remove the K-wires and the baby recovers really well. So that's what about this is the surgical treatment of this is a very interesting paper, surgical treatment of displayed pediatric lateral condyle fractures of the humerus by posterior approach. I think everyone should go through this. So according to that only we had done this case. So with that, so we'll be talking about next we'll be talking about a 3 years 3 months old male baby. This is a multiple fixation. We used K-wires and screws actually. So posteromedial, this is the specialty of this case was that this is a more severe kind of lateral condyle fracture where you have a dislocation of the elbow also, and this is more severe, and this fixation goes into a more serious way. So the baby had a history of bike fall and treated with posterior slab at local orthopedics, and then came to us with swelling, deformity and tenderness. So we'll start up the video so that you can see the entire course of the baby. So this was the presentation of the baby. As you can see, it was completely dislocated, and there was a very huge chunk of lateral condyle. Then we had to go for an MRI and a 3D CT to see the position of the elbow and how badly the comminution is there. So that was the MRI exposing entire thing, and there was intra-articular complete disruption with soft tissue hingement also. So this is a very, very important thing, where whenever you get a more serious cases are these, when you have an elbow dislocation like that, and you have this clunk of reduction, and then you again dislocate it with like that, and with the compression at the lateral condyle alone, you will have the reduction. Otherwise without any, sorry, we'll just come to that. Yeah, so this is the dislocation, and with the compression at the lateral condyle alone, we are able to maintain the elbow in a stable way. So this is a very, very important maneuver when you are seeing this. So then what we do an air arthrogram, and then we do a arthrogram with dye. Next we see the entire condylar pattern, and then we see the reduction maneuver. As you can see in the with the arthrogram, it is even more clear. So next we go to the modified posterior lateral approach, that is from the posterior, and we dissect like that. Next we clear out the fragment. This is a large, huge chunk of the cartilaginous portion of the distal humerus lateral condyle. So then we make sure the posterior blood supply is still intact, and then we drill into it and take it in a retrograde fashion. We take it on the other side and make sure always this periosteal hinge is always intact, which gives the blood supply. So we take it in retrograde way. And then we reduce it back, intact soft tissue, as I told you. So most important thing is that. So next we put out other K-wires also in an oblique fashion to make sure there is good reduction. So transarticularly also put a K-wire, and this is the final fixation. So with that we cut out and we leave the K-wires intact inside, bent inside, we leave the K-wires inside. So then we get a good closure with soft tissue around it. So that's the post-op K-wire. And this baby did really well after that. He went on to have complete union and good range of movements. So, so finally talking about topics to debate actually, are we really going to do a closed reduction or an open reduction? Always understand that for a closed reduction, you have to know how to do a good arthrography. If at all you are very good at arthrography or get trained with one of your seniors or a pediatric orthopedician who is well versed with the arthrography, then CRIF is the best option with very little fibrosis and the baby does really well. And also ORIF, when it's a very complicated cases like 2 cases that I have shown, they are a little bad. So we have to do an open reduction for them, even if it is an acute fracture. Next, talking about K-wires and screws. K-wires are proven to be really good, but from some studies tell that screws are giving better compression and better results, but it's still debatable. So next, buried or exposed K-wires. Buried in a study they tell that buried K-wires are not that great. Exposed K-wires are easier to remove without any anesthesia and reduce the cost and give very good reduction and results. So next, posterolateral and anterolateral. There is always a debate about which approach to take when you're doing an open reduction. So in this, an anterolateral approach is also been it has been told, but we used to have a debate in Mumbai, and in Mumbai, whenever we used to have a case like this, that anterolaterally you are not having any control over what is happening behind. So the periosteal hinge, whatever is behind, which is giving the complete blood supply, if you drill through it with a K-wire, then that is the most dangerous thing that you can do. So what they should tell is you open up the entire thing from the posterior and watch the blood supply and then reduce it and then put a safe K-wires. So I am trained in posterolateral and I have never done anterolateral. I think the other speakers can give their opinion about it. So timing and removal of implants, especially around 5 to 6 weeks is very good time for a baby to heal, especially less than 5 years, 5 weeks is more than enough. If it is more than 5 years, then around 5 to 6 weeks, 6 weeks is very good time for implant removal and very good physio. And as Sagar sir and Roshan sir have stressed upon it, always give active assisted range of movement exercises and never do passive range of movements. And as Roshan sir does, I also don't trust many of the physios. I am very scared because they do it so rigorously. Sometimes the K-wires break if at all we have left in, or sometimes what happens is whatever reduction we have achieved, that also gets lost. So all these things can happen and myositis can happen. So it's a little risky thing. And also I put my babies on indomethacin for a short term, like say 10 or 15 days in the first 2 weeks, and also put on vitamin C to avoid stiffness. So that does a very good thing for me, for my babies. So about that, talking about why did we talk about those exercises? I told you something like I'll be telling something very dangerous that is going to happen if you're not cautious. So this is what happened. Sorry for the bad quality of this. I got from a parent actually. So this was treated by one of the adult orthosurgeon. I'm not blaming him. I know that this kind of programs very few people attend. So this is what the problem was. Looks very innocent, right? Very, very innocent in the first thing. The first mistake that he did was he did not take an oblique views. And second thing was he did not follow up the baby the next week. What happens? He slid in his lap. This is after 1 month. It is completely displaced and it is in a very bad position now. So next what happened? This is after 2 months. 2 months, it has gone into a very bad non-union status. Now we have to do a open reduction and freshen the edges. So next another case. This I really don't know. It came, I think Sagar sir also. This case has gone to Sagar sir also. I just thought I'll just show you this. So this was the situation, and guess what he did? Guess what the surgeon did for this? Guess what the surgeon did for this? So he did this. So there is absolutely no reduction, no compression, no follow-up, absolutely nothing. So it went on to this, and it went on to this. So it is an established non-union with myositis, and the baby has only some 60 to 90 degrees of range of movements. So the baby came to us. So I told them to be on physio, and then we'll see what can be done after a few weeks once the baby gains range of movements. But thing is, I'm talking only about acute fractures, so I won't be talking about this. and complications, as you have seen, most of the people have already told. So I'd like to end my talk here. So that's about that. So that is the importance of oblique X-rays and following up every week and doing a proper job with that. That's that. So thank you for the opportunity, sir. Thank you.
Thank you, Dr. Anand. And we are at the end of the talk. If any questions are there for the presenters, please, you can put in the chat box or you can ask now. If there is nothing, then Kasha sir or Anil sir can take over and give the ending remarks. Dr. Kasha, are you there? Dr. Anin, are you there? Murthy sir, Selva sir?
Sir, I guess everyone left us.
No, I'm sure they'll be there, but on the mute to this thing.
Yeah, I don't know.
So, then I think no one is responding. Shall we end the session here? Not able to unmute, it seems, Dr. Kasha. So let
some
him,
issue with that, sir. Yeah.
Let him try and do that.
Yeah. Yes, sir's back.
Yeah, Dr. Vidyasagar.
Murthy sir, Jappandi.
Everything fine, sir?
Aipoyindi sir, anni talks.
No. Internet, I was listening to last talk by Anand.
Yes, sir.
He nicely demonstrated and conservative treatment also is telling for some cases. That's what I'm surprised. Nowadays, everybody is operating, no cases are living.
Sir, no, sir. There is a
practical problem in the.
Yeah, so the main crux of conservative treatment is if you find an undisplaced fracture and you think it is not going to displace less than 2 mm displacement, both medially and laterally at the fracture ends, then best is put a cast and every week you get an X-ray out of the cast and monitor. Don't ask them to come after 4 weeks or 6 weeks so that you don't catch up with a non-union later on. Otherwise, any other displaced fracture would be routine reduction and pinning. Whether it's closed or open is left to the surgeon's choice. Idea is to get the anatomical reduction and immobilize them adequately till healing.
That's what was my last
problem is, most of the times patient don't turn up later. They come after 2 weeks or 3 weeks, it's already displaced. And in busy practice, every week getting the X-ray done is again a bigger headache under supervision because the technician doesn't know to get an oblique view done.
Yeah, so if there is a non-compliance, then pin and send them.
Yeah.
Sir, that's why I myself go and take the internal and external oblique views actually.
Anand, let's see after 2 years, will you do it or not?
I'm not as busy as you, sir, so I can do, I guess, actually.
That's what I'm telling. One problem is with the patient. Children is one problem, their parents is another problem.
Yes,
neither the
so
children will
parents
cooperate nor
problem in children, sir, actually.
Murthy sir, shall we end the session or are we going to give any remarks, sir?
Is a problem. Dealing with parents is a bigger problem, sir.
Yes. So anyway, this session is nice, sir. Very important, pertinent topics are discussed. I think this will enlighten us what to be done in the present day. Particularly for even for seniors like us also, it's a good topic. Thank you.
So thank you everyone, and we'll disperse now.
Thank you, sir.
Thank you, sir.
Good night.
Good night, sir. Thank you.
Thank you, sir. Thank you.
Good night.
Thank you all, singlet losing here.